Hello friends, today we shall talk about antimicrobial drugs, its general concentrations, and the main objectives of today's deliberation are to understand the antibacterial drugs. We will also try to explain about antiviral, antifungal and protozoal drugs. And finally, we will try to know about cancer chemotherapy. So first and foremost, concept of antimicrobial drugs. Antimicrobial drugs are the greatest contribution of the 20th century to therapeutics. They are one of the few drugs which can cure and not just palliate disease. Their importance is magnified in the developing countries where infectious disease predominate. Drugs in this class differ from all others in that they are designed to inhibit or kill the infecting organism and to have no minimal effect on the recipient. The basis of selective microbial toxicity is the action of the drug on a component of the microbe, for example, bacterial cell wall or metabolic processes, that is not found in the host or high affinity for certain microbial biomolecules. Antimicrobials are usually grouped as according to their activity against particular types of organisms. In antibacterial, we will study about tetracyclines. These are a class of antibiotics having a nucleus of 4 cyclic rings. All tetracyclines are slightly beta solids which are slightly water soluble, but then hydrochlorides are more soluble. Aqueous solutions are unstable. All have practically the same antimicrobial activity. The subsequently developed members have high lipid solubility, greater potency and some other differences. Mechanism of action. The tetracyclines are primarily bacteriostatic, inhibit protein synthesis by binding to 30S ribosomes in susceptible organism. Subsequent to such binding, attachment of amino acid tRNA to the receptor site of mRNA ribosome complex is interfered with. As a result, the peptide chain fails to grow. The sensitive organisms have an energy-dependent active transport process which concentrates tetracyclines intracellularly. In gram-negative bacteria, tetracyclines diffuse through porine channels as well. The more lipid-soluble members enter by passive diffusion also. The carrier involved in active transport of tetracyclines is absent in the host cells. Moreover, protein synthesizing apparatus of host cells is less susceptible to tetracyclines. These two factors are responsible for the selective toxicity of tetracyclines for the microbes. When originally introduced, tetracyclines inhibited practically all types of pathogenic microorganisms except fungi and viruses, hence the name broad-spectrum antibiotic. Resistance to tetracyclines develops slowly in a graded manner. In such bacteria, usually the tetracycline concentrating mechanism becomes less efficient or the bacteria acquire capacity to pump it out. Another mechanism is plasmid-mediated synthesis of a protection protein which protects the ribosomal binding site from tetracycline. Elaboration of tetracycline inactivating enzyme is an unimportant mechanism of the tetracycline resistance. Due to widespread use, tetracycline resistance has become common among gram-positive cocci, E. coli, Enterobacter, and many others. Incomplete cross-resistance is seen among different members of tetracycline group. Some organisms not responding to other tetracyclines may be inhibited by therapeutically attained concentrations of deoxycycline and minocycline, the most potent agent. Now its pharmacokinetics. The older tetracyclines are incompletely absorbed from GID. Absorption is better if taken in empty stomach. Deoxycycline and minocycline are completely absorbed irrespective of food. Tetracyclines have chelating property. form insoluble and unabsorbable complexes with calcium and other metals. Milk, iron preparations, non-systemic antacids and sucralfate reduce their absorption. Administration of these substances and tetracyclines should be staggered if they can't be avoided altogether. Now its administration. Oral capsule is the dosage form in which tetracyclines are most commonly administered. The capsule should be taken half hour before or 2 hours after food. Liquid oral preparations for pediatric use are banned in India. Tetracyclines are not recommended by intramuscular route because it's painful and absorption from the injection site is poor. Slow IV injection may be given in severe cases but is rarely required now. Now we will see some of its adverse effects. Its irritative effects are: tetracyclines have irritant property, can cause epigastric pain, nausea, vomiting and diarrhea on oral ingestion. The irritative diarrhea is to be distinguished from that due to spur infection. Odynophagia and esophageal ulceration has occurred to release of the material from capsules in the esophagus during swallowing, especially with doxycycline. Intramuscular injection of tetracyclines is very painful. Thrombophlebitis of the injected vein can occur, especially on repeated IV injection. Organ toxicity, this is a dose related. Liver damage, fatty infiltration of liver and jaundice occurs occasionally. Oxytetracycline and tetracycline are safer in this regard. Tetracyclines are risky in pregnant women, can precipitate acute hepatic necrosis which may be fatal. And in kidney damage, it's a risk only in the presence of existing kidney disease. All tetracyclines except doxycycline accumulate and enhance renal failure. It causes phototoxicity. A sunburn-like or other severe skin reaction on exposed parts is seen in some individuals. And in teeth and bones, tetracyclines have chelating property. Calcium tetracycline chelate gets deposited in developing teeth and bone. Given from mid-pregnancy to 3 months of extrauterine life, the deciduous teeth are affected. Brown discoloration, ill-formed teeth which are more susceptible to caries. Tetracyclines given between 3 months and 6 years of age affect the crown of permanent anterior dentition. It causes diabetes insipidus. Democyclocycline antagonizes ADH action and reduces urine concentrating ability of the kidney. It has been tried in patients with inappropriate ADH secretion. Now we will study about antiviral drugs. Viruses are the ultimate expression of parasitism. They not only take nutrition from the host cell but also direct its metabolic machinery to synthesize new virus particles. Viral chemotherapy therefore was considered impossible as it would require interference with cellular metabolism in the host. However, in the past 50 years, virus-directed enzymes have been identified in the infected cell, and some viruses have few enzymes of their own, which may have higher affinities for some antimetabolites or inhibitors than the regular cellular enzymes. In addition, drugs have been developed which target virus-specific steps like cell penetration, uncoating, reverse transcription, virus assembly or maturation, etc. In antiviral drugs, we will study about acyclovir. This deoxyguanosine analog antiviral drug requires a virus-specific enzyme for conversion to the active metabolic that inhibits DNA synthesis and viral replication. Acyclovir is preferentially taken up by the virus-infected cells because of selective generation of the active inhibitor in the virus-infected cell and its greater inhibitory effect on viral DNA synthesis. Acyclovir has low toxicity for host cells. A several hundredfold chemotherapeutic index has been noticed. Acyclovir is active only against herpes. Groups of viruses, HSV and VZV, have been found to develop resistance to acyclovir during therapy, the former primarily due to mutants deficient in thymidine kinase activity and the latter primarily by change in the specificity of virus-targeted enzyme so that its affinity for acyclovir is decreased. Now its pharmacokinetics. Only about 20% of an oral dose of acyclovir is absorbed. It is little plasma protein bound and is widely distributed, attaining CSF concentration, that is 50% of plasma concentration. After topical application, it penetrates cornea well. Acyclovir is primarily excreted unchanged in urine both by glomerular filtration and tubular secretion. Now, some of its use. Acyclovir is effective in patients with normal as well as deficient immune status. In genital herpes simplex, generally caused by type 2 virus, can be treated by topical, oral or perinatal acyclovir depending on stage and severity of disease. Herpes zoster. The varicella zoster virus is less susceptible to acyclovir. As such, high doses are needed and it should be used only in immunodeficient individuals or in severe cases. Acyclovir skin cream may be applied on herpetic ulcers. In chickenpox, in patients with immunodeficiency and in neonates only calls for specific therapy. Acyclovir is the drug of choice, reduces fever, eruptions, hastens healing and prevents visceral complications. Now, antifungal drug. These are drugs used for superficial and deep fungal infections. Fungal infections are mostly associated with the use of broad-spectrum antibiotics, corticosteroids, anti-cancer or immunosuppressant drugs, indwelling catheters and implants, and emergence of AIDS. As a result of breakdown of host defense mechanism by the above agents, saprophytic fungi easily invade living tissue. In antifungal, we will study about ketoconazole. It's the first orally effective broad-spectrum antifungal drug, useful in both dermatophytosis and deep mycosis. The oral absorption of ketoconazole is facilitated by gastric acidity because it's more soluble at lower pH. Hepatic metabolism is extensive. Metabolites are excreted in urine and feces. Elimination of ketoconazole is dose-dependent. Time varies from half an hour to 6 hours. Penetration in CSF is poor, therefore not effective in fungal meningitis. However, therapeutic concentrations are attained in the skin and vaginal fluid. Ketoconazole is much less toxic than AMB, but more side effects occur than with meconazole or fluconazole that have largely replaced it for systemic use. The most common side effects are nausea, vomiting, can be reduced by giving the drug with meals. Others are loss of appetite, headache, paresthesia, rash, and hair loss. The most important drawback of ketoconazole is its hormonal effects. It decreases androgen production from testes and displaces testosterone from protein-binding sites. Menstrual irregularities occur in some women due to suppression of estradiol synthesis. Mild and asymptomatic elevation of serum transaminase occurs in 5% patients, but serious hepatotoxicity is infrequent. It's contradicted in pregnant and nursing women. Now its interactions. Ketoconazole interact with several other drugs, due considerations must be given when they are co-prescribed with other drugs. H2 blockers, protein pump inhibitors and antacids decrease oral absorption of ketoconazole by reducing gastric acidity. The dangerous interaction with terfenadine, esomeprazole resulting in polymorphic ventricular tachycardia due to excessive rise in plasma levels of these drugs has resulted in their withdrawal. Now its use. Orally administered ketoconazole is effective in dermophytosis because it is concentrated in the stratum corneum. It is an alternative to grisfelovin, but is restricted due to potential adverse effects. Used as a lotion or shampoo, ketoconazole is quite effective in seborrhea of scalp and dandruff. Now we will see about metronidazole. It's a prototype nitronidazole introduced in 1959 for trichomoniasis and later found to be highly active amebicide. It has a broad spectrum cidal activity against anaerobic protozoa, including Giardia lamblia, in addition to the above two. Metronidazole does not affect aerobic bacteria. Clinically significant resistance has not developed among E. histolytica, but decreased responsiveness of T. vaginalis has been observed in some areas. Anaerobic bacteria and G. lamblia also can develop metronidazole resistance, but this is a clinically problem only in case of H. pylori. Metronidazole is selectively toxic to anaerobic and aerophilic microorganisms. After entering the cell by diffusion, its nitro group is reduced by certain redox proteins operative only in anaerobic microbes to a highly reactive nitro radical, which exerts cytotoxicity. The nitro radical of metronidazole acts as an electron sink which competes with the biological electron acceptors of the anaerobic organism for the electrons generated by the pyruvate ferredoxine oxidase reductase enzyme pathway of pyruvate oxidation. The energy metabolism of anaerobes that have no mitochondria is thus disrupted. Aerobic environment attenuates cytotoxicity of metronidazole by inhibiting its reductive activation. Moreover, oxygen competes with the nitro radical of metronidazole for the free electrons generated during energy metabolism of anaerobes. Anaerobes which develop metronidazole resistance become deficient in the mechanism that generates the reactive nitro radical from it or have lower levels of PFOR. Metronidazole, in addition, has been found to inhibit cell-mediated immunity, to induce mutagenesis and to cause radiosensitization. Its pharmacokinetics is almost completely absorbed from the small intestines. Little unabsorbed drug reaches the colon. Is widely distributed in the body, attaining therapeutic concentration in vaginal secretion, semen, saliva, and CSF. Metabolism occurs in liver primarily by oxidation and glucuronide conjugation, followed by renal excretion. Some of its adverse effects are: side effects of metronidazole are relatively frequent and unpleasant, but mostly non-serious. Anorexia, nausea, metallic taste, and abdominal cramps are the most common. Looseness of stool is occasional. Less frequent side effects are headache, glossitis, dryness of mouth, and dizziness. Prolonged administration may cause peripheral neuropathy and CNS effects. Thrombophlebitis of the injected vein occurs if the solution is not well diluted. Now its interaction. A disulfiram-like intolerance to alcohol occurs in some patients taking metronidazole. Enzyme inducers may reduce its therapeutic effect. Cimetidine can reduce metronidazole metabolism. Its dose may need to be decreased. Metronidazole enhances warfarin action by inhibiting its metabolism. It can decrease renal elimination of lithium and precipitate toxicity. Now, some of its uses. In amoebiasis, metronidazole is a first-line drug for all forms of amoebic infection. Many dosage regimens have been tried. Metronidazole is less effective than many luminal amoebicides in eradicating amoebic cysts from the colon because it's nearly completely absorbed from the upper bowel. Giardiasis is highly effective in a dose of 400 mg. TDS for 7 days. A shorter course of 3 days with 2 grams per day is equally effective. Trichomonas vaginalis, it's a drug of choice. 2 gram single dose is preferred. Additional intravaginal treatment is needed only in refractory cases. Repeated courses may be necessary in some patients, but should be given with gaps of 4 to 6 weeks. Now friends, we will study about cancer chemotherapy. Cancer is basically a disease of cells characterized by a shift in the control mechanism that governs cell proliferation and differentiation. Cells that have undergone neoplastic transformation usually express cell surface antigens that may be of normal fetal type, may display other signs of apparent immaturity, and may exhibit quantitative or qualitative chromosomal abnormalities, including various translocations and the appearance of amplified gene sequences. Such cells proliferate excessively and form local tumors that can compress or invade adjacent normal structures. Its mechanism of action. Cancer is the uncontrolled growth of cells coupled with malignant behavior, invasion and metastasis. It's caused by the interaction between genetic susceptibility and environmental factors. These factors led to accumulation of genetic mutations in oncogenes and tumor suppressor genes that help to prevent cancer, which gives cancer cells their malignant characteristics such as uncontrolled growth. In the broad sense, most chemotherapeutic drugs work by impairing mitosis, effectively targeting fast-dividing cells. As these drugs cause damage to cells, they are termed cytotoxic. They prevent mitosis by various mechanisms, including damaging DNA and inhibition of the cellular machinery involved in cell division. As chemotherapy affects cell division, tumors with high growth rates, such as acute myelogenous leukemia and the aggressive lymphomas, including Hodgkin's disease, are more sensitive to chemotherapy, as a larger proportion of the targeted cells are undergoing cell division at any time. Malignancies with slower growth rates, such as indolent lymphomas, tend to respond to chemotherapy much more modestly. Heterogenic tumors may also display varying sensitivities to chemotherapeutic agents, depending on the subclonal populations within the tumor. This brings us to end the lecture. Hope you have enjoyed and understood. Thank you and goodbye.